Welcome to this concise video log on caring for an older woman with HIV on multiple co-medications. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and Vive Healthcare. This vlog was recorded by Dr. Jonathan Appelbaum. Please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Dr. Jonathan Appelbaum from Florida State University College of Medicine. I'm an internist, geriatrician, and HIV specialist. And I want to tell you about a patient I just saw who represents a challenging type of case that I often encounter. And so I'm going to go through some of the details of the case. So this is a 70-year-old woman who was diagnosed with HIV at age 50. She's been virologically suppressed since her diagnosis. She's very adherent. And her current regimen is a fixed combination of L-Vitegravir, Cobicistat, FTC, and TDF. Like many of my older patients, she has several comorbidities. She has hypertension, osteoporosis, and mild cognitive impairment. And she comes in actually urged to come in by her daughter because she's been losing weight over the past year. The daughter's concerned about this. She's on several medications, including amlodipine, hydrochlorothiazide, lisinopril, atorvastatin, alendronate, aspirin, and calcium carbonate. Her labs are actually pretty good. Her CD4 count is 463. Her viral load is undetectable. And some of her other parameters, her BMI is 19.7, and that's down from a BMI in the low 20s previously. Her cholesterol is 186, hematocrit is 35, and all the other parameters on her CBC are normal. Her creatinine is 1.4 with an estimated GFR of about 42. Her TSH is normal, and she it does not have either hepatitis B or hepatitis C. So let me a little bit about her social history, and this is important as a geriatrician and primary care physician. She lives alone in an assisted living facility. Her daughter lives nearby and visits regularly, and as I mentioned, her daughter's concerned because she's noticed that her mother has lost about 10 pounds in the past year. When I asked the patient, she describes herself as feeling tired. She has no energy and really isn't able to do much in the way of physical activity. And then when I inquired, she reported that she's fallen a few times recently. On examination, she's thin and in no distress. Her blood pressure is really good at 128/78, and really the rest of her exam is unremarkable. I performed a get up and go test, which is a test where you have the patient sit up from a chair, trying not to use her hands or arms to raise herself, have her walk 10 meters in a straight line, turn around, come back, and sit down. And she did this in about 16 seconds, with the normal being about under 12 seconds. So this patient represents several issues that we deal with with older patients, and in particular with our older patients who are co-infected with HIV. A geriatric definition of polypharmacy is taking 5 or more medications. And many of our patients who are living with HIV are considered at high risk for drug-drug interactions or adverse events due to polypharmacy. In one study, a pharmacist medication review of 248 older patients living with HIV, all of whom were 50 years of age or older, showed that the mean number of medications that they were taking were 14.2, and 11.6 of those were non-HIV related medications. And of that population of 248, 35% receiving 16 or more medications. In further evaluation, almost 2/3 of those patients were receiving 1 or more inappropriate prescriptions. So the question is, are additional medications providing benefits to our patients? And in fact, the more medications the patient is taking, the more have been associated with greater mortality. So what are the consequences of a patient taking polypharmacy, taking more than 5 medications? Well, You run the risk of decreased adherence. Patients will forget to take medications, particularly if they're multiple doses per day. There is a much greater risk of drug-drug interactions, which are mostly under or overappreciated. Many of our patients are underdosed in antidepressants due to the possibility of drug-drug interactions. We also run the risk of adverse drug reactions and oftentimes overlapping adverse events. And the thing that we as geriatricians really hate is when you order a medication to treat a side effect of another medication. We worry about drug-disease interactions. So does one medication worsen an existing condition? And then there's the issue of inertia and difficulty deprescribing or stopping medications that either harm or are no longer providing benefit. I want to talk about another condition, which is frailty, which is a multi-system syndrome. And this is a syndrome that really reflects biology rather than chronologic age. And it's a syndrome that's associated with the loss of functional homeostasis. In other words, the ability of the body to recover from stressors, and is associated with excessive mortality and morbidity in our patients. So how do we define frailty? Well, Linda Fried, who is probably one of the world's experts on the syndrome of frailty, talks about 5 conditions. One is weight loss, mostly due to sarcopenia, loss of muscle, low grip strength, exhaustion, slow walking time, as defined by the time get up and go test of more than 12 seconds, and low activity. And I think if you go back to the patient I described, she really fits 4 out of these 5 criteria. Frailty is more common and more prevalent in patients living with HIV than in uninfected patients. In an assessment of frailty in a cohort of 521 persons living with HIV and in a similar cohort that was uninfected, the prevalence of frailty was much increased, as we can see on this graph, with the incidence increasing with increasing age, but even prevalent in what we consider to be relatively young patients, 45 to 50. Some of the risk factors for frailty are, in addition to HIV infection, are advancing age, smoking, chronic hepatitis C infection, depression, low BMI, and low waist to hip ratio. Frailty, we know frailty begins earlier and is more common in patients living with HIV. And as I mentioned, our patient has at least 4 of the markers of frailty. Unfortunately, frailty, once it's present, is hard to reverse. So we try to prevent frailty if at all possible. So what are some of the other issues with our patient that are potentially reversible? Well, as I mentioned before, polypharmacy really involves a holistic evaluation. One of the things I recommend for all of my patients is to put all of their medications, supplements, vitamins, over-the-counter remedies into a brown bag and bring it to me every time they come in for a visit, so I can really do a holistic and thorough medication reconciliation. One of the things we can do with our patient is perhaps reduce or combine her blood pressure medication. I would actually evaluate her standing and sitting blood pressure to see whether she may have some evidence of orthostasis, which is a common cause of falls in our elderly patient. Perhaps maybe she doesn't need the diuretic. I would question whether or not she still needs a statin, whether she's going to get benefit from that down the road. And then most importantly, I'm concerned about her declining renal function and the fact that she's still on TDF. So what are some of the guidelines around switching patients to reduce adverse events or drug-drug interactions? Well, most importantly, we need to assess what was the patient's prior history of using antiretroviral therapy. Did they have any prior resistance? Are there interactions with any therapies they're currently taking? And do we need to, in fact, decrease or increase any other medications they're taking? Some of the strategies to kind of consolidate ART in patients with no drug resistance is to perhaps switch to a 2-drug regimen. And there are two 2-drug regimens that are now currently available as a single dose tablet. If drug resistance is limited, some of the recommendations that we have are usually switching within a class from one high resistance barrier drug to another is probably safe. An example might be switching either from bictegravir to dolutegravir or vice versa. Between class switches are okay from a high resistance barrier drug to another, such as a boosted protease inhibitor to an integrase inhibitor. There is limited data and guidance for patients who have complex underlying resistance. So in those patients, you have to be really careful in trying to consolidate or switch for adverse events. So getting back to our patient, I actually have 2 additional metabolic concerns. I kind of mentioned her renal function and the fact that given her renal function, she really should not be on TDF at that level of GFR. And the other issue is the fact that she has osteoporosis and she's on bisphosphonate and calcium to try to correct that. So starting with her renal function has been declining. As I mentioned, due to her low GFR, she's going to need to stop the TDF. There are a couple of options. One might be to switch to tenofovir alafenamide, which is safe to use down to a GFR of 30 milliliters per minute. Another option might be to get her off tenofovir entirely, given the fact that we're not sure whether, in fact, her renal function will continue to decline. So I'm going to show you some data from the TANGO study, switching virologically suppressed patients to a 2-drug regimen of dolutegravir 3-TC versus remaining on a 3-drug regimen containing TAF. And the data that's shown here showed that there was a decline in GFR with the switch to dolutegravir 3-TC in the blue on the left graph. But remember that dolutegravir causes a decrease in GFR as the way we measure it, but in fact renal function does not change. So that's an artifact of dolutegravir. Looking at the right-sided graph, the markers of renal dysfunction, the retinol binding protein and the beta-2 microglobulin, really don't change significantly by the switch. So I think it's safe to go ahead and switch the patient to dolutegravir 3-TC and maintain at least a renal function. With regards to her osteoporosis, I'm going to look at the TANGO study again for additional guidance. And here showed that when you switch patients from a 3-drug regimen containing TAF to the 2-drug regimen of dolutegravir 3-TC, most of the parameters did not change, which is actually good. The procollagen 1 did increase, but that's a marker of osteoblastic activity, so a marker of increased bone formation. And then finally, I want to talk a little bit about drug-drug interactions. We think of dolutegravir 3-TC as being a very safe combination with very few drug-drug interactions, but there is one important drug-drug interaction that this patient needs to be cautioned about, and that's the interaction between dolutegravir and polyvalent cations. The 2 most common polyvalent cations that we clinically use are calcium and iron. And she's taking calcium carbonate. So it doesn't mean that she can't take her calcium carbonate. It just means that they need to be taken separately. So I would recommend that she take her dolutegravir 3-TC perhaps in the morning, and she take her calcium supplement in the evening, as long as they're apart by several hours. And again, the recommendation is that you don't take them within 2 hours. So in summary, my approach to our patient JL was the following. For her HIV, switching her to dolutegravir 3-TC to eliminate the potential interaction with her failing kidneys by continuing the tenofovir. And I'll follow up to make sure, in fact, that this does not cause any loss of control over HIV. For her hypertension, I did decide to stop her hydrochlorothiazide, and I switched to a fixed dose combination of a calcium channel blocker and an ARB, which is available. So that actually eliminated 2 of her medications. I decided that the benefit of the atorvastatin, given her age and her frailty, was probably not warranted. So we made a decision, shared decision making, that her atorvastatin was stopped. I again advised her not to take her calcium pills at the same time she takes her new HIV medication. I also felt that physical therapy ought to evaluate her for the possibility of some sort of an assistive device to help prevent her from falling. And then we considered sending her for a full geriatric evaluation. So in conclusion, this was a complex patient with multiple comorbidities, in addition polypharmacy, which I think in the long run, this patient was helped by careful evaluation of her medical regimen. Thank you.